Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I am with Ethan. How are you doing today?
Doing great, Dennis. Thanks. How are you?
I'm doing well. I appreciate you coming on. If you wouldn't mind, though, since this is the first time on the podcast, would you mind doing just a quick introduction of yourself?
Yeah, you bet. So I'm Ethan Miles. I'm a board-certified family medicine physician. Recently retired after 24 years in the Army. Did Uniformed Services University residency out of Fort Hood. And then following that, went to 3rd Ranger Battalion as a battalion surgeon, and then the Regimental Special Troops Battalion. And after about 5 years, took a 2-year break and then went back as the regimental surgeon from 2013 to 2018. Following that, I did a kind of double stint of the Maneuver Center of Excellence surgeon, and then was also assigned to one of the battalions, 1504 up at 82nd as one of the remote docs. And then just recently retired and now started on as the Chief Medical Officer for North American Rescue.
Perfect. So definitely lots of experience, both conventional and in the special operations community. And what I wanted to talk to you about is fairly recently, I think on Facebook, but I'm sure it was on others, you had made a post about patient positioning. And I guess why do I need to even worry about patient positioning? The litters are flat. Obviously, God intended our patients to be like that.
Absolutely, right? As long as you're in a good position, who cares about your patient, right? That's the
right?
Most important thing. So, I mean, really, it was you, talking with you on patient positioning and how we might be able to help make that easier through product development. And it's kind of one of those forgotten about things that people certainly, I would say actually most people, not all, but most people don't train that and don't really practice that. And so I think a lot of times simple, low cost, cheaper, free interventions get overlooked. And I think especially as you start looking at prolonged field care, which is certainly the way that the DoD is kind of pivoting and looking to, I think as you look at prolonged field care, it's a lot of those simple things that we can pull from that and use as medics and providers in the far forward environment.
Perfect. So I guess when I think about positioning, I think about TBI, and I grab whatever happens to be around me and shove it under the patient's head, and now TBI is fixed. I guess that, and what other things is patient positioning useful for?
Yeah, so certainly TBI. So, first off too, I'm not an ICU physician. And so if you really want to get into patient positioning and changes in positioning, especially for ventilated patients, really sick patients, get some ICU time, go talk with some ICU nurses, some of the ICU experts. And they'll give you a deep education. So TBI is one of the things that we first think about when we think about elevating the head of the bed and patient positioning. Pretty simple and likely effective intervention. Jury's still out on really definitive data that says that absolutely is going to help improve outcomes. But likely very little harm that you would actually be doing, and probably would be getting some help. So in my kind of litmus test, that passes right there. And it's kind of one of those, we might as well go for it. You just got to improvise a little bit, since like you mentioned, litters are designed to transport patients, not necessarily treat, hold, and help patients out. It's designed to get them from point A to point B in a manner that's most efficient for us, not the patient.
Right.
So certainly TBI, generally when you talk about TBI and elevation of the head of the bed, somewhere around 30 to 60 degrees, there's a lot of looks at that. If you cruise through the studies, you can find studies to show anything. But generally, it's accepted that ICP goes down as you elevate the head, and then it starts to increase as you lay flat. That's been shown in healthy patients. So kind of extrapolate that to a patient where we're worried about increased intracranial pressure, and let's go ahead and elevate the head of the bed, see if we can help with some of that. So that's certainly one of the ones that we kind of look at first as an indication for our first look at how do we change a patient position to help them out.
Okay. So, in some of the training I do, I found that, even with just oxygenation, the Soros only gives you so much, or some kind of oxygen generator only gives you so much. Oxygen tanks last only so long. Just through patient positioning, I've actually been able to, increase SpO2 just by changing the position. I mean, am I imagining that happened, or was a wish granted? Right.
Yeah, well, I didn't watch it at that time, but likely that you are right. You know what you're talking about, certainly. So that kind of moves on to another indication for patient positioning, and that's ventilation. So when you look at the lungs and how they're able to exchange oxygen and how we're able to get air in and out, it's certainly beneficial if we can get patients into a position other than laying supine on their back, like we always like to put them in. So when you do lay down, even if you're healthy, your lung volume gets reduced, right? Part of that's because your mediastinum, maybe a little bit of abdominal pressure increase as well. And then there's some impedance that you could have to ventilation. There's also some regional distribution changes for ventilation and perfusion when you're laying down supine. So we look at that and say, hey, how can we help this out, right? So you elevate them up and they're going to get a little bit better lung volume. They're going to get a little bit better mechanics as we try to ventilate them. And that could be either mechanical ventilation or the patient breathing on their own. Just look at some people when they lay down, and not to get too far into airway yet, but as people lay down, that's generally not the most comfortable position. And you can see that, patients that aren't oxygenating well, it can make them feel very panicked. It's not a good feeling to be hypoxic. That's a very kind of bad feeling. And so a lot of times patients will naturally kind of sit up and feel like it helps them breathe better. And it's like I've always told all my medics, in general, patients are really good at breathing. People are good at breathing. They want to keep breathing.
Yep.
So let them do it. So.
Right. Hence like the tripod position.
Yeah, absolutely. I mean, which brings in the other one that has gotten a lot more attention over the last several years, but the airway management, specifically looking at patients and how to help them manage an airway. For again, kind of traditional is that patient's going to lay down and then you're going to take care of them. And fortunately, we've moved more into let the patient do what they need to maintain their airway. And it's pretty incredible how well patients can take care of themselves sometimes. Sometimes you just got to not get in their way, and they're going to do the right thing. And then we mess them up when we give them a bunch of medications and make them go into positions that they didn't want to be in the first place.
Right. Now, I mean, obviously this is not like a magic thing. Sometimes even, just changing their position is not going to win the day. Sometimes you do have to do that escalation of force and, take the patient's airway, put them on a ventilator. But in an interim, or when that equipment may not be available, is this a viable option?
Yeah, absolutely. I mean, you got to do what you can. And again, patient positioning, you can do without any equipment. Doesn't cost you anything. It may cost you a little time and effort, but you don't have to have special equipment. You don't even have to have real advanced training, right? I mean, it's pretty straightforward and basic. So, and some of the times, like you mentioned, all it does is it buys you a little bit of time, right? Especially when it comes to airway, it can buy you time until you can get your crike set up or whatever next intervention you need to do. The one thing I'd mention too, though, in airway, if you're positioning a patient for an obstructed airway or a pending obstructed airway, as you do go to crike them, that is where your position becomes a lot more important, right? And you can certainly crike someone when they're sitting up, but you really got to think about that patient positioning and what position is going to set you, the provider, up for success. So getting your equipment out, having your patient prep, making sure their head's midline, their neck's midline, they're not twisted around, so you hit the jugular instead of the trachea, stuff like that. That's one time when you kind of say, okay, my position of comfort is going to take precedence for a minute or two, and then we get the patient right back to where they need to be.
Yeah, I mean, that makes 100% sense, and it makes the whole procedure go faster when you're not fighting, patient positioning, trying to get your gear. You feel uncomfortable. I mean, that just extends out that whole procedure, and it makes it also a lot more likely you're going to fail.
Yeah. Do you guys at the schoolhouse, do you practice alternate positions for crikes, or is it kind of primarily?
Well, I mean, do we practice it? It's classic positioning, right? Patient's always laying down. They're always unconscious and still. Yeah. Where the extra training comes in is usually when the guy rushes in to do the thing, right? And he didn't position the patient. So he's, sitting up, or he's on his back, or like whatever crazy situation. Like, this is completely the student's creation. He chose this adventure and is moving forward with it. But I wouldn't say it's a routine practice. It's one of those things that people kind of mention, but then when it comes time to real hands-on skill, generally it's on their back.
Yeah.
And I'm not super uncomfortable with that. I think, considering how frequently they get to train in the school, I would think, let's show them this is, the best case scenario. This is what you want. And, if you can get that down, which I would argue that we're good at, okay, just because the frequency we train, I would not say we're great at, because of just the frequent, once you leave the schoolhouse, the frequency of training that guys actually get, those skills degrade,
Yeah. It's like any low frequency, high importance, skill,
right?
And that's certainly one of them. Not many crikes are being done, but when you do need to do it, you need to nail it.
Right, absolutely. And I mean, even talking to CRNAs, like just the other day, I did a podcast with one of the MAUs CRNAs, and he was like, "I'm going to go on vacation for a few weeks, and I'm going to feel rusty when I go back to work." And that's somebody who does this multiple times every day.
Yeah.
So it's not just the medic's fault, or the medics are being lazy. They're just not necessarily getting the opportunities to stay on that edge where we would like them to be anyway.
Yeah, absolutely. That's the rub, right?
Yeah, absolutely. So we're talking about all these amazing things and the miracles that can happen when you just change the patient's position. What can be some of the downsides of changing a position on maybe a patient who isn't quite ready to be jostled around?
Yeah. So I think one of the first things that comes to my mind is anytime you move a patient, you're risking the last intervention that you did, or any number of the interventions that you did, right? Which is why we always preach, every time you move a patient, recheck all your interventions, right? So if you applied a junctional, or you applied a binder, or even if you packed a wound and now you've moved them, you run the risk of dislodging that hemostatic or that junctional, right? And then you get a rebleed. So that's one. Certainly with airway, we're always conscious about losing an airway and validating, making sure that it's in the proper position. Chest tube, did you block it off? Did you kink it? Do we need to, put another needle D in as we do it? And some of these actually make it easier on you as a provider, right? So if we've got, if you've done a chest tube on the left side and you roll them over onto the right side, and they're kind of in a recovery position on the right side, then that's a lot easier for you, right? Then you can manage that, and it's right there in front of you, especially if you know the right side's good. Put that side down, and you got more room on the left side. So that's a good one. It's always a little bit tough on some of the junctional wounds, transporting those, right? Just because junctionals typically are a little bit unstable, and difficult to get in the right spot.
Yeah. Always you got to be super careful, whenever you move, especially when you're dealing with improvised junctionals, notorious. You get it to work and then, a butterfly lands on his forehead and suddenly comes loose, But, it's just it's one of those things where you just have to train to make a bomb-proof or as near a bomb-proof type intervention. That's one of the things I think I would also like to, if I could be king for a day as far as training goes, is how to really bomb-proof your equipment as far as those IVs. They love to just jump out of people's arms because we're putting a 1-inch piece of tape on the tubing when, in reality, I'm using duct tape and wrapping that guy's arm because I really do not want that thing to fall out. Or securing the crikes and securing your junctionals or whatever intervention that you would be really sad if it fell out, making sure that thing is secured really well.
Yeah, absolutely.
So, other than threats to your interventions, I've also noticed when I'm changing a patient positioning, maybe oxygenation improves, but I also see some effects to hemodynamics, kind of like an orthostatic type hypotension. Is that kind of universal?
I wouldn't say it's universal. It's every patient's going to respond a little bit different, right? Because they've got different physiology, different baseline characteristics. So, and sometimes patients respond in ways that they shouldn't. Right.
Okay.
Not all your patients read the books and know that, okay, the head of the bed's elevated 45 degrees. Now I should be ventilating better and I should drop my pressures, but they do for some reason. So, I think that gets back to our last point of anytime you make an intervention, you got to reassess, right? Yep. So you made an intervention. So in the case of a patient that's not oxygenating well, you make an intervention, you elevate the head of the bed, maybe 45 degrees. And then you want to watch them, right? And you want to reassess and see how they're doing with that intervention. If they seem to be doing worse in that intervention, no problem. We can buy some time. We can lay them back down and then give us a little pause to think about what's going on. But I wouldn't say there's a really with anything, I wouldn't say there's a universal response with patients as far as positioning changes go.
Yeah. And always... one thing I always preach is, build yourself a safety net. If you do an intervention and things go south, whether that's, administering some kind of medication, that could be, whatever, right? Changing their position, you're going to pay for it one way or the other. You're going to gain in one area, you're going to lose in another. And if you build yourself a safety net, so when you start to lose in an area, then you're able to intervene in a positive way, right? So I need to change this patient's position because oxygenation is bad and I have no other way to increase his oxygenation. However, I expect that his pressures are going to go down, or that's the thing I'm worried about. Well, then, be prepared to give him blood, be prepared to do something so that doesn't happen. Or if it does happen, it's not nearly as bad. It's not catastrophic.
Yeah. And it's, I always taught my medics, what's killing my patient. Right. And so they'd hear me over their shoulder as they're, doing a patient trauma lane and say, okay, what's killing your patient right now? What's the number one thing that's killing him? Okay, cool. Yeah. What are you doing to treat that? All right. What's the number two thing that's trying to kill him? Right. Something's trying to kill your patient. So your job is to go through, find that and intervene.
Mm-hmm. So, you won me over, right? I'm going to position my patients properly from now and forever. You mentioned that this is, it's free or very low cost. I mean, it seems really inconvenient when I have to shove my aid bag or what other gear underneath this guy. Is it, from an operational side, since, you've been in the Ranger Regiment, from an operational side, is this something that's worth buying gear, or is this something that just go ahead and go off the environment, you'll be fine?
Yeah, I mean, I never cease to be amazed at how creative medics can get when you give them a task and very, very little resources, right? They're really good at figuring it out. I do think, though, that there's areas for equipment improval, right? So, I mean, we've had litters with the same basic design for a long, long time. And so is there a way that we can design these litters better? Is there a way that we can, without adding a whole lot of weight, we can, make it so you can do some changes? I think that's absolutely an area to look into. That's kind of one of the things that I'm excited about on the civilian retired side now is you can be a lot more flexible sometimes on the outside and say, okay, here's a problem. And then we can put resources towards it and move a little bit quicker when you are industry versus, trying to talk industry into it. So yeah, absolutely think so. I don't know, where specifically this would go in each situation, right? Is this part of, would an add-on piece be part of a prolonged field care kind of speedball, or is this part of a vehicle kit? So if you do get into a situation where you need to position that patient a little bit differently, you can add that on. It's certainly going to be hard to talk your squad guys into carrying a lot more than a litter or a sked right? Hey, I'm going to add on. So weight and cubes is absolutely essential if you're going to go far, far forward. However, most of the interventions and discussions that we're having is less so immediate point of injury and becomes increasingly more important, I would say, as you get away from the X. Okay.
So, and to be honest, I've never been a gear guy. I don't look for the best, Gucciest, coolest thing. I've tried to find what works and just train with that until I can find something that works better, or I can become more aware of what the downfalls of something is and look for something that doesn't have that. However, I've definitely seen a lot of improvised things in my time, and generally I've found the pre-made things generally work better because they're purpose built. But I've also seen improvised things work very well as well.
Yeah, if I'm using an aid bag to keep someone upright, I'm going to want that aid bag back. I'm going to need
at some point,
bag, right? So yeah, absolutely. Especially with patient positioning, and if they're going to be there for any prolonged period of time, right? Again, if you're going to go from the mode of transporting a patient to a patient's going to be on this litter for a little while, then we need to really think about how we can best set that up for the patient. And like you said, a lot of times that means a pre-made device or add-on that we can make.
Yeah. And I mean, now that we're talking about devices, one thing I was thinking about, they recently came a report out of Ukraine that 10% of their hospitals have been destroyed. So, when you're thinking about casualties, how many beds do you have? How many hospital beds do you have? When those things start running out because they've been blown up, what's going to be left? It's going to be your litter, and you have an incredibly mobile thing that a patient can be on. How can I improve that and now start to create an improvised version of that hospital bed? Is that kind of a viable thing?
Yeah, I mean, I think that's a great point. And when you look at like Ukraine, or you look at some of the LISCO discussion that's going on, mobility is a key, right? We've got to be mobile. We've got to be able to clear the battlefield. We've got to be able to pick up from one position and move to another, maintain smaller footprints. And so if you're a casualty that may not make it back to rear echelons for, hours or days or weeks, that we've got to start looking at that litter as a patient bed, right? So if you go, just outside my window, there's, Piedmont, so big ICU, right? If you go to their ICU, they've got tricked out multi-$1,000 ICU beds that'll tilt patients and rotate them and do all this kind of stuff. So what can we take from the ICU? What kind of ideas can we steal and then bring them to the battlefield? So if you are that patient and you get put on a litter at the point of injury, and now you're going to be on that thing days, either in transport vehicles or in CCPs or makeshift field hospitals, roll ones, we've got to modify that thing for you. So you're not getting, pressure sores, and you're not, I think every medic listening has probably slept on a litter, and get sleep deprived enough and it's comfy, but I would not want to be on that thing and not moving for hours. You better give me a lot of ketamine.
Right. I mean, and it's not, these are not complex answers, right? You can essentially take that ICU bed, right? And essentially you could probably, in the size of a small backpack, recreate it with, got air mattresses, you could have litter backs, you could have litter poles, in a litter, and a very small footprint that is pretty easily transportable, recreate that ICU level bed. Maybe it wouldn't be as great, but definitely would be enough to do the job.
Yep. You get some, if you can modify it so you can get the patient up 30 to 60 degrees, you could do right or left lateral positioning, then I think you're doing great stuff.
Yeah. Able to get the patient's legs up, things like that.
Yep.
Yeah. Now we talked about, more LISCO, PFC, extended care things. Do you think positioning has any place in like T-Tri-C?
I think it does. For the most, it's what's your definition of T-Tri-C, right?
Sure.
So, strictly getting off the X, speed is the most important thing, right? So that trumps all. Get your patient off the X, get them to a secure area. So, that we're good. Is when you start looking at the early interventions that'll help the most. I think the two biggest things that come to mind is, number one is airway position. That's an immediate, but that, a lot of that goes back to our training of where we're not forcing a patient to lay down when they can't maintain their airway laying down, right? We let them sit up or be in recovery position on the litter or the SCEDCO as we're dragging them. And then the other one would be TBI. I'm a little less worried about, some of the nursing stuff and rotating them when we're in TC3, elevating it for, extremities for burns and all that. We can do that, but not in the TC3 care under fire, technical field care phases.
Yeah. No, that makes 100% sense. Leaving, nobody's worried about bed sores, when you're like getting shot at, right? So you're gonna, those are all living people problems, right? So first you gotta save the guy's life. But like you mentioned, even a T-Tri-C positioning can definitely aid you rather than hinder you anyway.
Yep.
And also another thing, kind of a little bit off this topic, but just to take an advantage of somebody who was helping the Ranger Battalion during GWAT. Why do you think Ranger Battalion did such a great job as far as reducing preventable death? Like, if you could summarize it.
All right. Super biased here. So that's my disclaimer.
Sure. Right. So
I think a few things. One is, there's an article that we wrote with Colonel Coatwall Monty, myself, Kurt Conklin, and a few others that were on there that really kind of talked about the culture and how they implemented a lot of these things before guys like me came along. But one is early leadership involvement. So when McChrystal made medical one of the big four, I think that was it seems pretty basic, but it was pretty revolutionary, right? That he said medical is going to be one of the top four things that you guys need to be trained on and be a master of, right? And really master the basics. So that implemented a culture in Ranger Regiment where everybody is expected to care for a casualty. Whether you're the RTO, you're the cook, you're the RCO, it doesn't matter. You are going to do Ranger First Responder. So I think that was one. And along with that culture came a lot of flexibility and empowerment for guys like me to come along and say, hey, I think we need to be doing this. And really it was like, okay, doc, you do doc stuff. And if that's what you want to do, then you do it. So we were able to form these teams and really kind of innovate and go. So I think, where we've saved the most, you look at like Ranger First Responder, having people be masters of the basics at TC3, far and away, that was probably the most important. And then as we kind of go up the scale and we had advanced Ranger First Responders, we modified that program and we made, 11 Bravos that were, phenomenal medics. I mean, they were beating medics in some instances when you went and looked at them versus the rest of the Army. And then our SOCMs, who I hold near and dear to my heart, our Ranger medics, I think they're best in the business. I think they have a very good ability to span are you a medic or are you a shooter, right? And that's where you see different, especially soft units, and they'll tip the spectrum, right? Of, no, I'm a shooter and I'm going to let my med skills kind of go. Yes, I'm technically the medic, but whatever, right? I'm going to shooter. And then you get some that are medics and really not proficient at shoot, move, and communicate and being on the battlefield. And so I think you've got to have a good blend. And so I think, over the years, they, year after year, they just do a great job of that at Ranger Regiment.
Yeah, I mean, I think it shows, especially when they come to the refresher courses, generally very, very proficient. And I think it's just simply because they practice at it. Like there's no magic to it. Yeah.
Well, and part of it, I was fortunate enough to go down to 3rd Battalion a couple months ago, and they were doing their 2-week Ranger Medic Assessment and Validation, right? And so there's not many units that will run their medics every year through an assessment and validation, and truly an assessment where at the end of that 2 weeks, you're either fired because you're not cutting it, you're rehabilitated, or you maintain your job, or they say, you know what, you're doing great. We're gonna start advancing you. So it's a true, can you perform as advertised? And right. I think in medicine, we all tend to assume that we're good and say, yep, I got it. And I know those protocols, but how often do we truly test ourselves and put ourselves up in front of others and see if we're really cutting it?
Yeah, that's definitely a complaint that I've voiced to the other instructors that I'm with is, medics, we love to talk like way the frick up here because it makes us feel good. It makes us look good.
Yep.
And all the things. Everybody wants to feel special, right?
Yep.
But
especially when it comes senior, right? And so how many times do you see the senior medics standing hands in pockets and pointing out the things that junior medics are doing? No, man.
Of course.
You get down there and do it too. I mean, I'll never forget my first CTM that I did with 3rd Ranger Battalion. I was a student, and I mean, they didn't let up on me at all because I was the doc. I mean, and I fell on my face and I learned a ton.
Yeah. Yeah. I mean, people, like, this is a serious business that we're in. Mm-hmm. And people have to let go of their freaking egos and open their ears sometimes and just absorb, right? Yeah. Just learn as much as you can. you can talk smack about somebody else after you've already demonstrated you have the collateral to go ahead and do that, right?
Yep.
But at first, you have to perform. That's rule number one.
Absolutely.
So, I mean, that's kind of what I had. Did we miss anything or?
No, I mean, I thought, for the viewers, you brought up some great points about if you look through the CPGs, which everybody should be doing, how many of the CPGs mention patient positioning, right? And that really hit home with me when you brought that up. And I think it's like 5 of the CPGs, right, have patient positioning. And so I never really thought about that because I think that's something as you look through the CPG, you skip over because it's not sexy, right? There's nothing sexy about, in fact, I'm sure when your viewers are looking and they see, patient positioning, like snooze fest, right? And hopefully they're still awake, but so it's not sexy, but you look through and you go, man, I've skipped over all that stuff. And I never really noticed that, even though I'd read them all. You kind of go, yep, patient positioning, got it. But then do we really translate that to our patients, to how we train and to how we actually treat patients? So I thought that was a great point that you brought up.
Yeah. Well, thank you.
Yeah.
But you're right. People pass over basics because they're looking for that. I think they're looking for that nugget of information that, helps you shine above others. And it's kind of goes away this, like, when people talk about nursing care, they're like, ugh, like baths, right? Yep. But there's so much more. And when you really think about it, who's taking care of your patients in the hospital? It's the nursing staff.
Yep.
But anyway, hey Ethan, I really appreciate you coming on.
Yeah, absolutely. Thanks for having me on. I really appreciate it. You're doing awesome work on this, so it's an honor to be part of it.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy is waiting there for you.